Good afternoon and welcome to the Commission on Race and Access to Opportunity meeting for October the 24th, 2023. Certainly pleased to have all of you here. I would remind everyone, including our members on the Commission, if you will silence your cell phones, it will save you from a slightly potentially embarrassing moment if you'll do that now. Lead staff is Brandon White, Committee Assistant Brett Gillespie. We appreciate the work of both of these two vital staff members. And I will now ask Brett to call the roll.
Senator Berg. Present. Senator Neal. Senator Westerfield. Here. Representative Brown.
Here.
Representative Heverin.
Here.
Representative Kulkarni. Ms. Baird. Here. Mr. Coleman. Mr. Davis. Ms. Drake, Dr. Jones, Co-Chair Gibbons,
Present.
Co-Chair Timoney.
Here. We do have a quorum and as such are duly constituted to do business. Moment of personal privilege. Ms. Baird, I'm going to be calling on you to introduce yourself, tell a little bit about yourself, and in so doing, I want to reemphasize the importance of our citizen members and stress to you, Ms. Baird, and our other citizen members, you are, by your involvement in this commission, a fully committed member, active and engaged in all ways that we have authority to act. So you are equal to the person sitting to the right of you, the left of you, and the person sitting right here in the chair that I'm sitting in. You are equal in terms of power, ability to ask questions, delve into issues. So do not be hesitant as you see something pique your interest to raise your hand, be recognized by me, and then called upon to engage in the process. So with that, you have involuntarily raised your hand, and you are now recognized for the purpose of introducing yourself. We're excited to have you on board.
Thank you. Thank you very much for having me. My name is Kimberly Henderson Baird. I'm the Fayette Commonwealth's attorney in Lexington, Kentucky. I was appointed a year and 24 days ago, but I have been in my office for 27 years. And so I'm very excited to be on the commission and working with everyone, not only here, but also in the audience as well. Thank you.
Thank you. And we also recognize the fact that you are the first African-American female in Kentucky to serve in the role of Fayette Commonwealth's attorney. Congratulations and thanks for your leadership. Yes, what you model is so important for all of us. I do remind members the commission purpose statement is something that we start every meeting with to refocus and reorient ourselves on our purpose. This is in statute. The purpose of the commission shall be to conduct studies and research on issues where disparities may exist across the sectors of educational equity, child welfare, health, economic opportunity, juvenile justice, criminal justice, and any other sectors that are deemed relevant in an effort to identify areas of improvement in providing services and opportunities for minority communities. With that, we are excited to start today's meeting with the first business item, which is approval of our August and our September minutes. I understand we need approval of both. So we're going to hold on that. Someone just stepped out of the room and we lost our quorum. We're going to hold that and come right back to that in just a moment. So we'll move directly on into our first presenters, which is a group coming to the table to present information on the issue of birthing centers. So if those engaged in that conversation would come forward, as all of you look like seasoned veterans of this process, you know to identify yourselves for the record, and then the floor is certainly yours. So we look forward to the presentation.
Thank you, Mr. Chairman. Jason Nemus, representative of 33rd District. That's Jefferson, Oldham, and Shelby counties.
I'm Mary Catherine DeLoder with the Kentucky Birth Coalition. Push the green button.
I'm Meredith Strayhorn. I am a licensed certified professional midwife in the state of Kentucky.
Good afternoon. I'm Liz McQuillan, the Chief Policy Officer for Metro United Way.
Thank you, Mr. Chairman. I appreciate you you calling us to the committee today. We believe in this bill. This is the fifth year that we will have introduced it. We've been working on it. We've improved it over and over. Last year it was a big discussion, obviously, in the Senate, and I think Senator Shelley Funky Frohmeyer is the principal sponsor there and has made a lot of improvements. It passed the L&O committee in the House 18-0, and we look at we believe we have some significant support in the House. I'll let my friends at the table do the heavy lifting today because they have much more persuasive words to say than I do, but I want to thank you for having us.
Thank you, Co-Chair Givens and Co-Chair Timoney and the rest of the commission members for this opportunity to speak today. As I said, my name is Mary Catherine DeLoder, and I represent the Kentucky Birth Coalition. We are a grassroots coalition of families seeking to expand childbirth options in the Commonwealth. For the legislators on the commission, several of you have heard about this topic of freestanding birth centers multiple times already during the session and the interim, and we're going to do our best today to present this topic in a way that relates specifically to the mission of this commission. Freestanding birth centers are not a new concept in Kentucky. We have existing regulations for the licensing and for Medicaid reimbursement of these facilities. However, there have been no freestanding birth centers in Kentucky since the 1980s. The legislation that Representative Nemes referred to that he and Senator Funke Fromeyer have carried in their respective chambers would seek to change that with two main points to those pieces of legislation. They would modernize the existing facility licensure requirements for freestanding birth centers and also remove the unnecessary certificate of need barrier for freestanding birth centers. Certificate of need, for those who may not be familiar, is a process where a proposed health facility must first prove a need for the facility before being granted permission to open. And in that process, it allows competitors to oppose the new facility. And there's an entire other task force this interim focusing on that, so we're not going to focus on that today. I do want to mention that there's a broad group of organizations in Kentucky that do support the access to freestanding birth centers, including Metro United Way, Louisville Urban League, Black Birth Justice, Granny's Birth Initiative, Mama to Mama, Kentucky Youth Advocates, Play Cousins Collective, the Ready for K Alliance, the American College of Nurse Midwives Kentucky affiliate, and the National Association of Certified Professional Midwives Kentucky chapter, and lots more. So with that, I'm going to turn things over to Meredith.
Thank you so much. I am Meredith Strayhorn. Like I said, I'm a licensed certified professional midwife here in the state of Kentucky. And so I just wanted to talk a little bit about what birth centers are and the importance of being able to offer access in the state. So a freestanding birth center is a standalone physical location other than a hospital specializing in normal childbirth without common medical interventions. Birth centers are only recommended for low-risk labors and are small in size, only about 2 to 3 beds. Mothers who choose a birth center receive a full course of prenatal and postpartum care, and these prenatal care appointments include extensive education on nutrition, exercise, childbirth preparation, breastfeeding, infant care, and self-care. Most birth centers offer multiple postpartum visits and also include at least one home visit as well. This is different from home birth in that this is a destination for birth rather than in a private residence. And birth centers offer a home-like setting where care is focused on family-centered, holistic wellness model. They emphasize relationship building between providers and pregnant people and patient-centered birth planning and labor. Visits are usually at least 30 to 60 minutes long, which allows midwives to establish better relationships with their clients and also allows for more extensive education. Birth centers do not offer surgery or anesthesia, and there are no epidurals or pain management drugs used for labor, although many non-pharmaceutical forms of pain management are utilized, such as movement and water therapy. So birth centers reduce the number of interventions used in the course of labor and delivery while improving patient experience and lowering costs, saving more than $1,000 per birth. There was a review of 32 studies of birth centers that found that positive health outcomes for women, including lower rates of cesareans compared with women delivering in hospitals. Another recent study of more than 15,000 birth center labors found that only 6% resulted in cesareans with no maternal deaths. And then according to the CDC, the rate of cesarean in Kentucky is 34.7. So that is quite the comparison. So according to the Commonwealth Fund, research shows that a wide range of community-based approaches could improve maternal health outcomes for patients' experiences while also potentially reducing costs. These approaches could especially benefit those that are most at risk for poor outcomes, and particularly people of color and those with low income. Options include enhancing patient access to a broader range of services and incentivizing health systems and providers to adopt evidence-based, equity-centered models of care. The Department of Health and Human Services Center for Medicare and Medicaid Services found that in their Strong Start for Mothers and Babies initiative, birth centers showed significantly improved outcomes that may offer health benefits and cost savings far beyond the infant's first year of life due to lowering the rate of preterm births and cesareans. Some mothers are choosing to give birth out of hospitals because they have a fear of giving birth in the hospital due to risk of exposure to things like COVID or the flu, along with increased awareness of racial disparities in our healthcare system. The option to birth in a birth center would keep otherwise healthy patients from being exposed to sicknesses, and also would free up those beds for critically ill patients that truly need the hospital bed. Other birthing people do not have home environments that are conducive to home birth. They may live in apartments or in overcrowded or small homes. They might live in multi-generational homes. However, they still would like to have access to the option to birth out of the hospital. A third issue that plagues our Black community is white coat syndrome, so stemming from a history of systemic racism in our medical industrial complex. Oftentimes people will delay care because of the fear of mistreatment or their repeated experiences of not being listened to. And delaying care decreases the opportunity for education for proactive habits that increase our odds, proactive habits and lifestyle changes that decrease the risk for developing complications. This mistrust in the system or in care providers also increases our odds of having complications, to name a few, increased stress levels, high blood pressure, and other things that are going to be risk factors that lead to other complications as well. When I ask clients to describe their ideal birth, I've had several clients say, "I just want to live. I don't want to die in the hospital, and that's why I found you." And maternal mortality is a very real issue. Nationally, Black women are 2 to 4 more times likely to die from childbirth-related causes in comparison to white women, and that rate can vary drastically depending on where you are in the country. In the Kentucky Public Health Maternal Mortality Review Annual Report 2021, the rate of pregnancy-related deaths for Black women was 40.2 per 100,000 live births, in comparison to the rate of pregnancy-related deaths of white women, 13.1 per 100,000 live births. Some factors that influence these rates are structural and systemic factors like racism, implicit bias, lack of access to quality health care, and poverty. And the data from the latest American Community Survey shows that Kentucky has the 6th highest poverty rate in the country at 16.5% and is well above the national average. The CMS bulletin describing the Strong Start for Mothers and Newborns initiative states that the evaluation compared participants in Strong Start to other women enrolled in Medicaid with similar demographic characteristics and medical risks. These were identified in birth certificates and in Medicaid claims. And also who lived in the same counties but received care in non-Strong Start practices. It showed that regardless of where they gave birth, whether it was a birth center or the hospital, the birth center participants had costs that were at least $2,010 lower on average from birth through the first year for each mother-infant dyad. Birth center participants had preterm birth rates that were 25% lower than those that were compared to them, along with better birth outcomes in multiple areas such as average birth weight, VBACs, the infant emergency department visits, and just to name a few. So Black women in my community and surrounding communities are seeking out Black midwives who can provide high-quality midwifery care for our low-risk clients. And I want to be able to offer all of my potential clients those same high-quality rights to giving birth wherever they choose, and that includes a freestanding birth center. Black-owned, culturally sensitive birth centers are a promising means of reducing racial disparities in maternal morbidity and mortality. And there are more than 384 birth centers in the United States, and it's estimated that only about 20 of them are led by people of color. So limited access to capital and resources is a significant barrier to people of color starting and owning birth centers. And then another obstacle to the growth of birth centers is Medicaid's limited or sometimes lack of reimbursement for the services they provide. And the certificate of need is an added barrier in Kentucky to opening a freestanding birth center. A few testimonials. One woman named Mrs. Edie Onque said that her experiences at the birth center was a welcome contrast from her first birth, where she said a doctor behaved like he was at an auto body shop. She said he instructed her to brusquely, "Hey mom, open up for me," as he tried to check her cervix without explaining who he was or what he intended to do. "You're supposed to be relaxed, trying to literally bring life into the world," Miss Edie Onque said. It's also influenced by Lynetta Lafayette's choice to have her first child at a birth center. She said, "I wanted to feel more in control or informed." She said, "Like I could identify with my birth workers in the same way that my grandmother was born with midwives in the South." It was community experience where everyone rallied together as part of the culture to guide this mother through her birth. Ms. Lafayette also said it was important to her that women of color be a part of her care. "I was just terrified of not being able to be heard and seen by my birthing team," she said. "I liked that I was surrounded by Black women. That was the most comforting thing, like being in a womb of my own." Today, we have Kentuckians crossing our borders to give birth in nearby birth centers in Indiana and in Tennessee. And there are over 300 birth centers nationwide, and Kentucky is one of 8 states that have 0 freestanding birth centers. Our Commonwealth deserves to keep the dollars in the state, and all Kentucky residents deserve access to options for high-quality models of maternity care in various birthing settings. Thank you.
All right. Good afternoon, everybody. Again, I'm Liz McQuillan with Metro United Way. Thank you to Co-Chairs Givens and Timoney and members of the Commission for the opportunity to speak with you today about an issue that really affects equity in our community. In 2022, Metro United Way commissioned a study conducted by the Center for Health Equity to examine maternal experiences in Jefferson County. The aim was to better understand the perspective of prenatal and pregnancy care experiences from mothers who are less likely to access prenatal care or face barriers in accessing prenatal care, specifically Black and immigrant or refugee mothers and mothers who have experienced substance use disorder. Participation in prenatal care leads to significantly more positive outcomes for parents and babies. However, we know that not all groups are equally likely to access prenatal care during their pregnancies. So data shows what people have lived and experienced for decades, especially for women and communities of color, not just in Jefferson County, but across the Commonwealth. Zip codes that are disproportionately low income and majority Black in Jefferson County have lower rates of prenatal care access. Similarly, access to prenatal care is not evenly distributed throughout Jefferson County along racial or ethnic lines. White mothers access prenatal care at higher rates than Black or Hispanic mothers. So this study, researchers conducted focus groups and interviews with 34 recent parents, so parents who had given birth within the past 3 years. They also conducted surveys, and we think that this data is valuable because it is not just cold hard numbers, but it conveys the lived experiences of these mothers in our community. So several themes emerged from the focus group and the interview findings. So all of the parents in the study were excited about their pregnancies and looking forward to milestones in their pregnancies like sonograms, gender reveals, things like that. Most of the parents reported positive experiences with prenatal care. They expressed trust in their providers, and they stated that they felt heard and well taken care of. However, some participants reported traumatic prenatal, pregnancy, and delivery experiences. Parents reported that accessing prenatal care or knowing where to go was burdensome, and this can be particularly true for parents who are recent immigrants or refugees or are new to Louisville. Cost and insurance coverage prevented some parents from receiving the types of care that they desired, and disruptions in care and miscommunications were common across reports. Black mothers reported that they experienced medical racism from providers, particularly when they requested treatment for pain close to or during their delivery. And parents felt like they had to be their own advocates, which can be challenging during a pregnancy or childbirth. So some of the values that the participants expressed that they appreciated during their prenatal care or wish they had experienced really focused around building trusting relationships with providers who valued their birth plans and took their concerns seriously. And as Meredith alluded to, Black parents expressed a desire to see more Black women and nurse midwives as part of their care team. They felt that those providers would provide more responsive care for them and would be more responsive to their culturally needs. So there are 6 different recommendations, but I'm going to focus on the 2 bolded ones today. Investments to increase the number of caseworkers and doulas could ensure meaningful access for all mothers, and which is critical to helping them feel supported. These allied professionals provide aid and advocacy for expecting parents. The study also recommends expanding access and affordability of birth options, including births outside the hospital, unmedicated births, and models of care such as midwifery. While these options can be available in traditional medical settings, they are limited in Louisville, and there are currently no birth centers located in Kentucky. One participant in this study traveled several hours while in labor to deliver at an accredited birth center in Nashville, a similar center, as Meredith mentioned, the Tree of Life Birth Center in Jeffersonville. The birth center model emphasizes relationship building and patient-centered birth planning and labor, which would address the concerns of the mothers who reported a strong distrust of medical providers from whom they'd experienced racism, and enable parents to build those trusting relationships and rapport with their prenatal care providers. Freestanding birth centers offer this strong start to parents by delivering strong outcomes and quality and health measures. Meredith alluded to some of these as well: lower cesarean rates for low-risk women, lower rates of elective delivery before 39 weeks, lower rates of postpartum hemorrhage, and higher breastfeeding uptake. Satisfaction with birthing experiences is higher under midwifery care, which can improve mental health outcomes for birthing mothers as well. Expanding safe and healthy birth options is a necessary step to expand equitable access to prenatal care and reduce inequities in Kentucky's maternal mortality and care statistics. Healthy pregnancies, labors, deliveries, and babies are essential in creating the strong households, thriving kids, and equitable communities that Metro United Way seeks for all Kentucky families. Thank you.
Well done. Good presentation. Senator Berg, you're recognized for the first question.
Thank you, Mr. Chairman, and thank you guys for your presentation. First a statement and then a serious question. First, my statement, pregnancy needs to be a qualifying event. Right now, if a woman finds out she's pregnant, she cannot go ahead and get health insurance. If she gets divorced, she can. If she has a baby, she can, but she can't for pregnancy, and that's something we need to change in this state. I know that personally because my first pregnancy, I was a resident at University of Louisville School of Medicine, and their health insurance specifically excluded pregnancy coverage. So I found myself pregnant with no health insurance to cover it. We can't have that for women. So this goes back to my real question. Somebody needs to explain to me the reimbursement model for these freestanding birth centers, and how do we assure that underserved populations are included in this model of healthcare delivery? Not just, assure that they have access to it, but assure that they are actually included in it. Thank you.
So as far as reimbursement from Medicaid, we have regulations currently that set out amounts, and I don't have those amounts with me today, but that is in our administrative regulations, which can be looked up. I think those are updated regularly, I believe, even though we don't have birth centers. I think that's probably following some federal guidance. And then as far as reimbursement models for private insurance, that would be, the birth center contracting with individual private insurance companies and kind of working that out on a case-by-case basis. I know that's been the experience that the birth center across the river from Louisville has shared about, that they are in network with some insurance plans, but not all, but they are working continuously to become able to be in network with more.
Senator Berg, I'm going to recognize you for another question. But before you do, let me ask the panel, because we've talked about this conversation for some years, not just this conversation, but the whole midwifery practice. Do a brief background for the panel on how we've gotten to where we are and explain where we are in Kentucky as it relates to licensed midwifery.
Sure. So there are two general types of midwives that are licensed in practice with a recognized Kentucky license. One is a type that is an APRN called a certified nurse midwife. That's someone who is generally a nurse and they decide that they want to go on and further their education and they become also a midwife. So they're sort of like a dual profession. So they're a nurse and a midwife, and in Kentucky they're licensed as APRNs. We have one institution that educates nurse midwives. That's Frontier Nursing University, which is currently in Versailles. Previously it was in Haydn. So if you've ever seen the historical photos of midwives on horseback in Appalachia, those are the midwives that were from Frontier Nursing Service, as it was then called. So we've had those type of midwives for a number of years. We've also had other community midwives always in Kentucky, but they haven't always had a pathway to practice legally. Until the 1970s, permits were issued to what was then termed lay midwives. And in 1975, the state stopped issuing permits. So if you were not a nurse midwife or an APRN, there was no legal pathway for you to practice. So all the other community midwives were basically underground from 1975 until 2019. And that is really where my organization, Kentucky Birth Coalition, got its roots, was starting to work in the legislature to change that, to create a legal pathway to practice for those community midwives. There's a certification called the Certified Professional Midwife, which is a nationally recognized credential. And so that was approved by the General Assembly in 2019. And so now that is overseen by the Board of Nursing, even though those midwives aren't nurses. But that's where the administrative body that issues the licenses is from. So we have two different categories of licensed midwives in Kentucky. To date, there have been about 34 licenses issued for certified professional midwives, which is the type of midwife that Meredith is. We've seen a real expansion since passing that legislation in students. I think you probably began your journey as a student after we got that legislation passed. And particularly, we've seen a number of Black students enter that pathway since that legislation was passed, and so that it's not sort of an under-the-table profession any longer. And there are, I believe, about 145 licensed nurse midwives in Kentucky. Some of them are practicing in hospitals. Some of them are practicing as educators. Some of them are practicing in home birth settings. And some of them are not practicing as nurse midwives. They maybe are employed as labor and delivery nurses or other things because they haven't been able to find employment as a nurse midwife. So hopefully that covers it all, Senator Givens.
Wonderfully well done, and thank you for your years of advocacy. This has been an example of citizen advocacy. Best, the work that you and others have done in this space has been powerful and impactful and wonderfully succinct history and very well spoken. Senator Berg, you have a question.
Thank you for the follow-up. So, in this bill, is there a way for us to require that a certain percentage of patients have to be Medicare patients or Medicare eligible patients so that we make sure we're not setting up just simply an elite private for pay out of pocket service for those women who want that experience?
That is not addressed in the current legislation.
So how as a state do we address that?
I think first we have to pave the way for these facilities to open. Once they can be open and sustainable, I know that many of the entrepreneurs who hope to open these birth centers that I have spoken to, they already work with Medicaid and Medicare populations, and that is where their passion lies, and they want to keep doing that. And so I know that that is what they hope to do. So I think we have to give them the opportunity to open those centers so that they can continue to serve those populations in that way.
And Senator, I don't know the 43 states that have it, what their percentages are. We may try to find that for you, but I think those states have a significant portion of their Medicare, Medicaid patients as well. So we'll try to get that for you.
I would really appreciate that because, you know, the last thing we want to do is purport this as a way to serve underserved women and then end up not serving any underserved women. So for me personally, I would like a guarantee in the bill that somehow we manipulate this system in such a way that a certain percentage of patients at each facility have to be Medicaid patients. And that's what hospitals do. You know, hospitals have to. They don't have a choice.
Senator Neal, you're recognized for the next question.
Well, thank you, Mr. Chairman. I tell you, the excellent historical presentation and the questions initiated by Senator Berg and the responses actually addressed the issues that I was thinking about. So thank you very much for that, and thank you for your testimony.
You know, the members of the panel seeking questions of these presenters. Seeing none, thank you all very much for your presentation.
Thank you, Mr. Chairman.
Yes.
Thank you.
Returning to an administrative function while the next group comes to the table, I will go ahead and invite the Kentucky overdose rate presenters to the table. And while they're coming to the table, I will entertain a motion that we adopt the minutes from the August and September meetings. Motion and second. All those in favor say aye. Aye. Any opposed? The ayes have it. Let the record reflect that the commission has approved the August and September minutes. I believe you must be Mr. Hubbard. Yes, sir. Mr. Hubbard, we are honored to have you here. Please make sure your light is green on your microphone. When you push the button, the light will become green. Introduce yourself for the record. We look forward to your presentation. And then, based on the agenda I have before me, you'll have some others that will be joining you at the table in just a few moments.
Thank you, Mr. Chairman, and my apologies. I will, with you all's permission, deliver my remarks. Any questions you may have, I have another engagement that I have to run and engage, and I don't want to hold up the other people who will be presenting to you, if that's okay.
We will certainly accommodate you in that way, sir. Please proceed.
Thank you very much. I am Brian Hubbard, and I am the Chairman and Executive Director of the Kentucky Opioid Abatement Advisory Commission. The commission was established by the General Assembly to administer 1/2 of the Commonwealth share of settlement funds paid by opioid distributors and manufacturers for their role in creating and perpetuating Kentucky's opioid epidemic, which is now in its 27th year. The Commission's charge is to solicit, award, and monitor grants to deliver prevention, treatment, and/or recovery services aimed at mitigating opioid use disorder, co-occurring substance use disorder, and any co-occurring mental health issues to impacted individuals. Total funds obtained through multi-state settlements successfully negotiated by Attorney General Daniel Cameron amount to nearly $900 million, of which the Commission's share approaches $450 million. The Commission's membership was announced by General Cameron in June of 2022. The Commission held its first formal business meeting on July 12, 2022. A grant application was developed, and an online grant application portal was activated on October 16, 2022. Since that time, the Commission has announced 2 rounds of grant awards. The first occurred in April of this year. At that time, 24 grassroots community-based organizations were awarded over $8 million in opioid abatement funds to deliver an array of prevention, treatment, and recovery services for each of Kentucky's 120 counties. On October 2nd, Attorney General Cameron announced $13.9 million in grants to another 34 grassroots community-based organizations whose opioid abatement services will also reach all of Kentucky's 120 counties. In addition to these awards, the Commission is fully funded Senate Bill 90's Innovative Criminal Justice Reform Pilot Project based on a behavioral health conditional dismissal model. This model prioritizes treatment of individuals apprehended in a state of active opioid dependence as a first resort alternative to the traditional model of arrest, prosecution, conviction, and incarceration. This 4-year project is being implemented in 11 counties at an annual cost of $10.5 million, with a total cost of $42 million. Total funds awarded this calendar year by the Commission exceed $32 million. An interactive map can now be found on Attorney General Cameron's official website, which displays the identities, sums, and locations of all grant projects funded by Commission dollars. Before the Commission began the grant review process, it conducted a series of 8 regional town halls between September and November of 2022 from Pikeville to Paducah. The purpose of these town halls was to engage Kentuckians from all walks of life in candid conversations as to what they have seen, lived, lost, and overcome since the introduction of OxyContin into eastern Kentucky in 1996. Each one was well attended, uninhibited, and visceral. At the beginning of each town hall, the Commission would present national, state, and regional data, which illustrated the evolving nature and scale of the opioid epidemic. The Commission relied on data generously provided by the Kentucky Injury Prevention Research Center. During the Commission's review of voluminous data sets, a new and startling truth emerged. Since the outset of the epidemic, opioids had affected mostly poor, working class, white families in Appalachia. But data revealed that in 2021, the impact of opioids began to reach well beyond Appalachia to urban, poor, and working class black families. That year marked the very first time that the rate of opioid-related deaths among black Kentuckians exceeded that of whites, at a rate of 50.2 individuals per 100,000 in population, compared to 42.7 among whites. This ominous and devastating change is driven by an equally ominous and devastating dynamic, which is the tidal wave of fentanyl that is flooding every state, county, city, and town across America. The vast majority of opioid deaths are now caused by fentanyl, with Kentuckians and black Kentuckians especially affected by fentanyl's lethality. In response, the Commission made a concerted effort to engage black faith and civic leadership in Louisville, Lexington, and West Kentucky for the purpose of planning additional town halls in each community. With their invaluable partnership, the Commission was able to build a trust bridge, which led to broad-based engagement with hundreds of black Kentuckians at Brandeis Elementary School in Louisville, the W.C. Wells Community Center in Paducah, and Consolidated Baptist Church in Lexington. The Commission then took deliberate steps to identify and fund grant opportunities aimed at delivering prevention, treatment, and recovery services to some of the communities hardest hit by the fentanyl wave, including the west end of Louisville. Among those receiving substantial awards are the Kentucky Harm Reduction Coalition, the YMCA of Greater Louisville, the Kentucky Alliance of Boys and Girls Club, and Young People in Recovery. The opioid epidemic is not an us problem or a them problem. It is a we problem. I would like to thank Attorney General Cameron for the exceptional leadership he has demonstrated by securing these settlement funds and leading Kentucky's fight against the insidious fentanyl executioner, which is pouring across our open, unprotected borders. We can win, we must win, and I am honored to help him do everything within our power to secure victory for all Kentuckians. Thank you, and I welcome any questions you may have.
Mr. Hubbard, thank you for the presentation. If you would refer back to your notes, there's a specific point that I find interesting as I take notes. That tipping point of 50.2 out of 100,000 black and 42.7 out of 100,000 white, you attached a year to that. What was that year again?
2021.
2021. And those numbers are from 2021.
Yes, sir.
Was that the first year in which the numbers started separating like that?
That is correct.
Okay. Interesting and disappointing and maddening and frustrating all at once. Senator Westerfield, you're recognized for the first question.
Thank you, Chairman. Mr. Hubbard, I appreciate that report, and it's alarming, and I'm glad that you all are keeping an eye on that. I just wanted to ask, and I don't want you to respond here today because it's not relevant, but I'm eager to see the responses to my requests about the Commission's proposed expenditure for the Ibogaine research. I believe you've got a list of questions that I had sent through Judiciary Committee staff, so I'm eager to see what those responses are. So I just wanted to take the opportunity to remind you that I asked for them.
Thank you, Senator. I reached out to your staff member on those questions to discuss those with her, and I'm waiting a call back.
Well, feel free to reach out directly to me if you need answers to questions.
I would be glad to. Thank you,
you.
sir.
Senator Berg, you have a question? Please proceed.
Thank you for your presentation, sir. And I may have just gotten lost in the course of it, but you said that your commission is in charge of $450 million of the $900 million. Is that correct?
Approaching that amount, yes.
Approaching that amount, and then you gave numbers where you all have distributed $32 million.
That is correct.
So what happened to the other $420 million?
That $450 million will be coming in tranches over the next 15 years. There are actuarial payments that are attached to each settlement achieved with each distributor and manufacturer. The total sum that will arrive for the state approximates $900 million. That will be paid starting last year all the way through 2038 in different incremental sums based on the settlements negotiated with each distributor and manufacturer. So we don't have a big pot of $450 million that we're sitting on. We're getting payments in $20, $25, $30 million a year, and that tapers off over time.
A follow-up, sir.
Please.
Thank you. So that $32 million that you've distributed, is that everything you've received to date?
That is the vast majority of money that we have received to date. There is some that is left over simply because the commission, through the review of proposals, exhausted the opportunities presented to fund viable projects.
Okay, thank you.
Thank you.
So, Mr. Hubbard, before we let you go, and this is a question I'm going to be putting to our other presenters on this same agenda item about overdose rates. Often I hear this referred to as deaths of despair. I'm stepping away from your presentation and your notes to ask you to speak briefly, and as I will them, speak briefly from the heart about what you've seen as it relates to individuals and families that have suffered from overdose deaths, from paths that were chosen that we so wish they hadn't have chosen. Speak briefly about how have we arrived here? One of the things I hope we pride ourselves on in the commission is when someone brings a crisis or a calamity, they also bring a solution. Programs, funding, grants, yes, 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 and yes. But in the long term, what do we need to do to change the arc of the pain that our fellow Kentuckians are suffering?
You ask a very broad and complicated question. And the response that I would give as Brian Hubbard, the individual, having listened from the official capacity to thousands of people speak over the past years. When I speak of Kentucky to people who are not from here, I will often describe it as a beautiful place populated by beautiful people, which is also home to a host of socioeconomic maladies which afflict diverse populations in common ways. We have generational pathologies at work in our state, which certainly I believe made Kentucky analogous to the drought-stricken forest struck by lightning at the time at which OxyContin was introduced into East Kentucky in 1996. The opioid epidemic is perhaps the most visible and tragic symptom of profound spiritual affliction within our society that is grounded in disconnection not just from each other, but disconnection from our own significance as representations of divinity here on earth, made in the images of an almighty creator. And insofar as that fundamental reality is not acknowledged, not seen, and is not reinforced in terms of the specialness of human life, we as friends, neighbors, and family members of everyone who is lost in the dark have an obligation to begin the repair of our social fabric at the most basic level by affirming the divine specialness of human life and the special and unique purpose every human being born within this Commonwealth has to contribute to the well-being of our broader society.
Well said. Thank you.
Thank you,
Appreciate
sir.
your presentation. We look forward to your continued hard work in this space. We have two other presenters on this agenda topic, and I invite them to come to the table. My agenda indicates that we have Ms. Walden and Ms. Parrish Wright. Please come forward and join us if you would. Identify yourselves for the record. We're honored to have you here, and then please proceed with your presentation.
Thank you. My name is Shamika Parrish Wright. I am the Executive Director of Vocal Kentucky, Voices of Community Activists and Leaders. We are a grassroots, nonprofit, membership-led organization, and our members, including myself and my whole staff, are impacted by issues that deal with homelessness, mass incarceration, HIV and AIDS, and what we call the failed war on drugs. I hope that you all have received the attachments that I sent before this meeting so that you can see that I'm really trying to focus on solutions. But Senator Givens, your question really was already in my script. Anytime I enter this kind of work, I think about the poverty that our state has been dealing with for a very long time. And I think about my introduction to community organizing, to advocacy, to the nonprofit sector comes from a very personal, professional, and community lens. I think that we have to look at all of these issues as both and we also know that too many people, too many voices have been left out. One death is too many, one death is avoidable, and one death needs a policy change to make a difference. When you ask that question to Brian Hubbard, who we have worked together to make sure that those community town halls were in the communities impacted the most around the state. We followed them around so much, they asked us, well, you're following us, are you going to apply? We have not applied for that funding. We want that funding to go to services and care. And my dear friend Sharita will talk about how that is put to place. But what we noticed is that people like myself, we've been dealing with each epidemic. It was the crack epidemic I grew up in. I watched my family die from heroin use. I watched my family die from AIDS and from the opioid crisis. And I have a father who spent 40 of his 56 years in and out of jail who would be here today had there been better policies and procedures to meet him where he is, where he was. I'm here, but I with all those childhood adversities, but I'm still here as a person who chooses not to use drugs. But I understand that many people are introduced to substances in a myriad of ways. This opioid funding and spending is not philanthropy. It is an attempt to right a bunch of wrongs in our state. So many communities have been impacted by this issue and overlooked. And now that this funding is coming through our state, it is important that it gets to the ground, to the people who need it most. And we all want to be on the right side of history. I'm honored to present to this commission because I know many of you from other work that I've done, but I've been here for representing work that supports poor people. And several of the people that I've brought here to testify before our legislative body are no longer with us because of an overdose. I see it every day on the streets in our community. My team goes out every day and they're meeting people where they are, and people are dying. We're on the side of life. And we also know that at any given moment, none of our work is touching everyone that currently uses substances in our state. We are meeting the people who have bottomed out, who are at the end of their rope. And we must have progressive policies and resources to back them up to make sure that we are saving and improving lives across the state. That is the only goal that I have. And harm reduction includes prevention. It includes making sure that there's options for people. And I wouldn't be here if those preventions wasn't in place in my community. I participated in the DARE program. I participated in all of the things. I almost became a police officer because I wanted to make a difference. So we must make sure that whatever lens we're wearing in this conversation, that we're considering the many, many people who will never be able to come before you. So with that said, as I said, I really appreciate you bringing that up. And the roadmap that I sent to you all really talks about how those settlement funds should be spent. We want you as a commission to make a recommendation to the legislative body to make sure that over 18 years, this money can be rerouted in a bad way. And we don't want that to happen. We've seen funding go places it shouldn't go before. This money isn't for police to paint their cars. This money isn't for new buildings for probation and parole. This money is for the people who are directly impacted by these issues. So we have a collective position that these funds that were secured in response to the dramatic increase in deaths and harms from the opioid pill dispensing stemming from corporate greed, that they provide an opportunity to more broadly address the damage of over 50 years of war policies grounded in criminalization, incarceration, and anti-evidence-based approaches to drug use. We're asking that you support the science, the data, and that we call on with our many partners across this nation that all states, counties, and municipalities to adopt the priorities of proven public health interventions. These interventions have the science. They show that harm reduction work. And we know that we can't really solve any of our issues with poverty in this state without dealing with the housing crisis, transportation, and access to services and care. None of the things we've talked about today, even with the birthing centers. Despite their role in reducing overdose deaths and improving lives, many, if not most, of these critical tools are unavailable to the vast majority of people right here in our beautiful state, especially those in the rural communities and the cities and the other parts of the state that aren't represented in the right way. I'm sorry about that. Everyone should have access to all forms of FDA-approved, science-approved, data-informed MAT, which medically assisted treatment, that harm reduction services. We have approved syringe exchanges. We have approved all these things. I'm a person with a heart condition, and I need medications to live. People need medications too to also get to a better place in life. These are so critical, and these innovations are needed, and we need the funding to follow the policies. We need the funding to follow the decision making. So the outreach and the wraparound services and support, we know that they work. We've seen them work. They continue to work, but we cannot let this moment fade. This is not just a moment in time. This is an opportunity to right a bunch of wrongs. So we want the communities and we want you to support policy and legislation that puts housing first, that gives people an option, that gives people low barriers where possible, that you let people use their choice of faith, their choice of outreach, and to have the support that they need ongoing. And then the last thing I'll add, addressing the collateral consequences of the drug war policies. This tough on crime, you can be tough on crime and honor people's humanity. We're not asking you to condone people breaking the law. We're asking you to support second chance employment, recovery to work programs, social support, all the things that we know help a person have a better life. Legal aid services should be made available for everyone that are dealing with this, job opportunities. We employ, even in our organization, we employ people who are in different stages of recovery. Some of our team are newly recovered. Some of them have spent the last 20 years in chaotic opioid use. So we support small community-based groups that are doing the work, because if they're saving 25 lives a year, that's worth saving. That's a Kentuckian who deserves to be here. So we have been following the process with the Abatement Commission to make sure the applications are accessible. They reduced it from 29 pages to 15 pages, but there are still some smaller groups and organizations who don't have the administrative capacity to get those things done. So we want to see more applicants. We've been working with our partners to make sure that we help people through that process, and we are showing up with our partners like the ACLU and other groups in advocacy moments to make sure the further criminalization and incarceration of people who use drugs disappears. If we reduce that, we reduce the need to build prisons and jails and the ability to have those resources be better spent in the community with the communities who are ready to serve. So just asking that the family piece, all of the sectors that you mentioned on why this commission has formed, this issue overlaps every one of those, from juvenile justice to housing to family to reunification. All of those things connect to this crisis. I want you all to be on the right side of history. Help us by making recommendations to your legislative body that they support harm reduction services and care. Thank you.
Please proceed.
and I am Sharita Walden. I'm the Executive Director for Kentucky Harm Reduction Coalition. And I'm going to stay with time. I want to address and respond to your question too, Senator. I come from a family of service individuals. My mother is, I'm from Chicago originally, and my mother and one of my stepfathers are both retired Chicago police officers, detectives, decorated officers. My biological father was a Vietnam War vet. He was honorably discharged and was able to participate in the Vietnam War as a Marine Corps man. He went over at about to turn 18 years old and came back dependent on cocaine, heroin, and alcohol. He died in 2012 with 10 years of sobriety in California. And then my dad, I always say I have 3 dads, my 2 stepdads and my bio dad. That's who created the great Sharita. My other stepfather is a pastor in Chicago. So I come from a family of service providers. Being within my community, working with my community and thinking about health, well-being, and safety have been a part of me. I also have uncles that have passed away from complications of AIDS and absolutely remember what the crack epidemic looked like in the 80s. I'm not going to repeat what Shamika shared. I think she shared a lot of what we both came here to speak on. My closing to this, harm reduction has definitely gained momentum in the language, and it's a trend. I came to tell you it's not a trend. Harm reduction is a part of prevention. Policies and laws that further criminalize or punish individuals due to their lack of access or inability to utilize the resources in the community to assist them in improving their life and their circumstances is an unintentional harm. I believe that everybody that comes to this space looks to meet the need. At the root of it, we all want to see people improve. We want to see people healthy. But I'm sitting here to say that we have to not negate how intersectionality really plays a part in this. I can say that we can do all these things, but I don't want to negate that poverty has a lot to do with where we're at. You know, no one woke up when I was running a treatment program. No one woke up and said, you know, at 10, stood up in front of their teacher and said, I want to be dependent on heroin. I want to lose my kids. I want to lose my job. I want to lose my car, my family, and my house. No one did that. Someone was trying to deal with and cope with the realities of what they cannot live with. And what we're trying to do is get people to live within a system that was not created to make them successful. And we have to take a look at that. We have to take a look at the reason why poverty is high in a neighborhood where we have food deserts, right? We have to take a look at why a child would take a gun outside and kill someone when they're also a kid that's going to work when they get out of school. They're going to work when they get out of school because they have to pay the bills with their family. You know why? Because they have a dad that's incarcerated and a mom that has died from a fatal overdose. And grandma, who thought she was done, is now parenting again. You're asking children who have the stressors of us as adults to carry that weight and carry it maturely without having the social maturity or the emotional maturity that they need to handle those issues. So what do we need? We need prevention. As a harm reductionist and as a licensed clinical alcohol and drug counselor for 16 years that I've been doing work in the prevention and social work and social service arena, what I see that works is prevention. Putting money into prevention, which is harm reduction, is not either or, it's and. It looks like providing funding for programs so that youth can have access to them. We did hear about Mr. Hubbard's commission and how they were able to fund some programming for the YMCA and the Boys and Girls Club. But we need to reimagine what it looks like to put people over policy. Treatment and recovery is absolutely needed. How many of you guys are asking the questions, though? There's a lot of crickets, I call them, where we're not talking about why there's been so many deaths, and we have so many treatment and recovery institutions in our state who have been getting money over the last 10 years. Where's the question behind that? Why do we have treatment and recovery centers that have deaths in their facilities? We don't ask those questions. So if you're going to continue to fund treatment and recovery programs, I beg you to ask them to prove the data. I would like for them, Senator, to ask the question of, are you saying you're successful because you had a lot of pregnant women complete your program? Can you please break down the demographics? Can you please share with me, is it success for the white community? Because we experienced a 5% decrease in this state. The 5% decrease was in the white community. There was an 8.9% increase in the Black community. In that same report that our leader shared and said we experienced a decrease and we're making way. And I said, yet again, we have overlooked the entire state of Kentucky communities of color, because when we add in all other, because the way the data reported was white, Black, and other, how horrible does it feel to be othered first? But then to say we had a 5% decrease in our state, but I look at the report that is made public to nationally, it was almost a 14% increase in fatal overdose death rates in all communities of color in Kentucky. So tell me, who is making progress? Who is making progress? Those are the questions. So I came with a solution to encourage you to ask the questions when someone is bringing new legislative verbiage and they're bringing policies to you. How does it directly impact the communities that are most impacted? Are we going to be really targeting our areas, or are you going to tell me that and I had a great one here, are you going to send the message that, yes, we see you're dying in your community, but who are you voting for? Because that's the message that's sent. We see you dying, but are you going to vote? That's so unfair. And it is dehumanizing to sit back and look at our state, only acknowledge one community that is surviving. So I'm wrapping this up. As a harm reducer, as a person in this community, as an advocate for the people, because I am the people, I am asking you guys to ask the right questions. Ask the questions that will elicit the kinds of conversation that I heard today. I am actually impressed with all of you. I'm impressed by the questions I heard because I did not expect that. I'm asking you to ask the right questions. There's a lot of questions that's not being asked around here, and I'm curious about it. And I really wanted to sit here and answer some, so I'll be quiet.
I think we owe you some after that presentation. Well done to both of you. Thank you for your passion. I'm not surprised by either of you, your talent, your passion, your commitment. Thank you for being here. You wouldn't be standing in this space if you weren't passionate about it. Right. It's got to be a tough space to stand in. So thank you for doing that. I have Senator Neal with the first question.
Thank you, Mr. Chairman. Actually, I don't have a question. I want to thank these two presenters for the clarity and the power of the message that they brought here today. And I think it's unavoidable what you just said. And we all know that that's true. And I got the point. Ask the right questions. Get the right answers. And follow that information to effective conclusion. Thank you very much. I just want to thank you for that.
Thank you.
Thank you, Senator.
Thank you.
So you've both answered my question already. I'm not going to ask it again, but I want to follow up on something that I thought was a common thread running through Mr. Hubbard's response, and then I heard it in both of the statements the two of you made, and it was one of those, I guess you'd call it a light bulb moment for me, and I'm old enough that I shouldn't still be having light bulb moments. I should know all these things already, but he used the phrase lightning strike in a drought-stricken forest, talking about the way that the alignment of the stars led to the dismal place we are today as it relates to overdose deaths, opioid and fentanyl. I'm using some of the words that both of you put together, but I wrote down this sentence: we can't solve our overdose problems in the Commonwealth today without addressing joblessness, poverty, homelessness, and hopelessness.
Yes.
Speak to that again one more time briefly.
I'll go first and add transportation. I've been saying that we can't fix our problems without that as well. We have a beautiful state, a lot of landscape, but it's hard for people to get to those services. We have people who are running services out of their vans, out of their cars. The people will always come together to form the community that we need. I mean, people don't like to talk about it, but there's always been safe use consumption sites. Some of them look like crack houses. Some of them look like bars. There's always, some of them was somebody's grandmother's basement. There's always been places where people found ways to come together to get whatever it is that they need at that moment. There's always been people like us who work on advocacy, prevention, and education. And we're right now working together with KY Policy and Apple Shop to make sure that we tell the story of every Kentuckian. But because for me, in our 120 county approach with Vocal Kentucky is less about the lines that separate us across the state, but the issues that unite us. We have a lot of uniting issues that are plaguing us. And we want to tell the data story for those who need that data. I live the data. I'm a product of the data. But I understand that some people need to see that. We have to tell the story of faith and resilience that comes from our faith groups and our churches and our faith leaders who've been coming together for many years to counsel, to help, to even help someone through the process of withdrawal. We also have to tell the story of our healthcare providers who are working night and day in many areas, getting in their vans, bringing supplies to the communities, to the hoods, to the hollers, to the suburban places where people are too embarrassed to come out and get the resources that are in their community. And then we have to tell the story of our young people who are too often being the first responders to these overdoses and people who want to shield them from it, but they're seeing it anyway when they're going home and they're finding their loved one unconscious and not knowing what to do. And that's why I really appreciate having the partnership. We're advocacy. We try to help where we can and fill in the gaps, but we must be partnered with service organizations who are taking that work right to the people in need. Right. So as somebody who's been homeless, as somebody who's lived on the streets and in my car, at every given moment, I knew I had a choice to do better, even though things were telling me to do something worse. And everybody needs that option to be able to make the choices they need. And if we treated these substance use issues like we do alcohol in this state, we celebrated when, it was banned and outlawed, then it was approved again, and now it's everywhere. But you can go to a bar down the street here and get clean alcohol that has been tested and proven, and you able to use it. You can stay there and drink all day if you want. You can leave and never come back. You can leave there and go into recovery and treatment. You can leave there and get a ride and go to home or to your church. That is the same option, a menu of services that people who choose to use drugs need. If we're not dealing with cutting off the true sources of the fentanyl poisoning, then how can we continue to criminalize the people who've received tainted products that they didn't know? So we need the test and strips, even though we were years behind. I do congratulate this legislator for doing that, and as well as the syringe. Even in my community, we cleaned up needles from our yards when I lived at Hemlock and Southern. And I was like, why are people throwing them away? We cleaned them up. We put flowers out, and people stopped throwing their needles there once we've put a needle box near there. Once we put a little library there, people thought that it was going to be used as a drug changing station, but it wasn't. It wasn't a drug exchange station. It was a place where people shared other items that they wanted to give away beyond the books. If we have the support at the legislative level, the people, the community will follow up and respond in a way that is positive, in a way that saves and improves lives. So yes, we are doing this and we won't stop, but we need your help to do more.
As a service provider, like Shamika said, I get an opportunity to take a very different look at what's going on. I'm directly there. So what I want people who don't get that opportunity to envision, I'm a storyteller too, so I can tell you what it looks like. what we've traditionally done in the treatment and recovery spaces is we have these wonderful, beautiful facilities that we bring people into, that we block away any access to the people who have supplied them with their substances, so our street pharmacists. We've removed chaos. We've removed any barrier to living this very peaceful and clean, nice, serene life. And then we give them a certificate and say, go home and keep doing it, okay? Where we failed as clinicians is understanding that we're dealing with a true illness, that we have now placed that person back in a space where their lights are going to be cut off because they really cannot have a job that will pay them more than what minimum wage is, with prices that are going up. They have childcare, but they don't qualify for childcare funding, so they can't navigate that system. They have Child Protective Services involvement, and they have to be in 3 different places at one time because no one communicates with each other. So they're getting in trouble and getting put back into the system or getting locked up with bench warrants because now they're not meeting this. You see how it just continues to go? I can go on and on. These are not stories I'm making up. These are stories of clients that I have worked with and unfortunately have lost custody of their children because they could not meet the rules of the system. So then we say to you, and you better not go back and drink or use, or you have relapsed. And I'm sitting here like, if I send somebody back into the same situation because they have no access to improve that, they've been told there's too many strikes against them, they should always and forever be dependent on the system, it's unfair of me to think that they're not going to go back and use. And let's not talk about rural counties, because rural counties lack access to treatment providers and they have to travel miles and miles, like to larger cities like Lexington and Louisville. Now we're really in trouble because we're saying, go back, have your sponsor, go to your meetings. They're like, hey, it's not a meeting here, it's a meeting 2 counties over. Oh my goodness. But when I go to visit their city or go to visit their town in Manchester, and I see they don't even have a bowling alley, or they don't have social activities, and I'm sitting here making a relapse prevention plan saying, you should go do these things, I'm setting them up for failure. So why not? Why not? Using looks like a pretty good idea now because I have no other choices. Once we start to look at substance use in and of itself is just us coping with life. I mean, for folks up here that's sitting here who have a glass of wine or the good old fashioned that I didn't learn about until I moved here, right? Have an old fashioned or a mint julep or something like that, or a cigarette or a smoke on the cigar. When once we realize that the difference is drug culture, you just don't want to do crack. You just don't like meth, but you do like to have a cocktail. You do like to relax. Once we normalize the fact that we all went through a pandemic and all of us have a qualifier of PTSD at this point, and we're all just trying to deal with it in our life, then we start to level the playing ground and say, you know what? If I, like this woman who was standing on the corner out in this heat, had her head down in a sign, and I heard her from my car as I tried not to look at her because I didn't have anything in my car but an open bottle of water that I had. And she said, I'm just so thirsty. And I said, I got a bottle of water, but I couldn't even finish it because she came over and said, please, can I have it? And I said, I drank out of it. She said, I don't care. I'm thirsty. Thank you so much. And she went back to the corner and I said, wow, my privilege is I had a really messy day today at work, but I get to go home. I get to sit on my couch and watch something like Family Guy and drink whatever I want, even if it's water out the sink. I have access to that. That's my privilege. Once I realize that people are dealing with things that I have not had to deal with, then I started to take a look at this differently. Like, wait a minute, if we have the supports in these communities, then using becomes less of a desire. We have to start taking a look at this as a public health problem. This is a social injustice problem. This is an inequity problem. This is a problem that we have a hospital being built on the west end of Louisville, and most of the people in that community that have records will probably not be able to qualify to work there. So they're going to walk past this big, beautiful potential place of employment and see that they cannot get in it. That's the problem we have. If people have what they need, they don't go into Dollar General and steal Tide. They know they can pay for it. We have to have the paradigm shift that people are not stealing because they're coming up. They're stealing because they're trying to survive, because they get $1,400 in food stamps and told they can't get nothing but food. They can't do anything. So you have created a system where I have to go to my sister and say, hey, give me $500 and I'm going to give you this. And then you get mad at us. You get mad at people and say, why are they doing that? I'm like, because she needs to put gas in her tank so she can go do the job so she can pay the fines. See how that works? But once we take that very hard look at our privilege, I have privilege, Shamika have privilege. We have two privileges sitting right here in front of you all. We are privileged. You all are privileged. We're speaking to you as peers, saying we get that. We have to take our glasses of privilege off and say, hey, the reality is, if I was in that situation, which I am with my $1,300 rent, I am. Sometimes I have to balance whether I'm going to put gas in today or get those extra few groceries I need in my refrigerator. I'm in that exact same position. I am not a six-figure ED. People see ED and be like, girl, you making it. I say, no, I'm not. I qualified for rent assistance last year. I am the people. I am my community. And thank you for the privilege for sitting at this table, because I am the people I cry about. My insurance, because I'm with a small agency, was $400 a month with a $10,000 deductible. So yes, I'm going to scream about insurance. Great question about insurance. I said, we got to dismantle the insurance, what their systems are. It's an oppressive system. That's what the answer is. I was listening to everything you guys said. I'm a product of that. I tried to go for an insurance company that told me with the underwriting that if I wanted to have children, it wouldn't be covered. This was a much lower plan. And if I had a mental health issue, I could do outpatient, but I couldn't do inpatient. I could do outpatient for substance use disorder treatment, go figure, catch this. But if I needed inpatient, I could not do it with this insurance. And I said, how do we have legislation that says that this is a qualifier and that I can get services that are not stigmatizing, that's not discriminatory, but I actually have an insurance provider who told me that if I meet these needs, and you know what, I did not get that insurance because I have seen a psychiatrist. And I was like, well, darn. So just sharing, because again, I am the people. I am dealing with the same struggles as the communities that I serve.
Well said. Thanks for sitting at the table. Appreciate
Thank
you
you.
both. Great conversation, great discussion. Look forward to your continued involvement in the work of this
Oh, yeah.
commission. Thank you.
Thank you.
Any other members seeking recognition? Senator Berg, for a brief statement before we adjourn.
Quick, no, this is a question for you guys. You have to come back. I'm sorry. This is a direct question, and thank you. And I apologize for talking so much, but this is an honest question. I'm going to be point blank direct. Okay, I lost a niece 4 weeks ago to an overdose. And in her case, the problem wasn't poverty. The problem was a dual diagnosis. The problem was mental illness that had never been adequately addressed. And not because of want of trying, because of honest want of finding providers that knew how to help and could deal with the situation and could actually impact positively. Is this a difference in the needs of our community? Or is your community also seeing dual diagnoses as a major problem?
Absolutely. It's devastating because we have tried the silo working with substance use disorder and mental health, and we have actually tried very hard to bring these as co-occurring, so you hear that terminology used. It's complex. And the reason why harm reduction, why I'm in this lane, a lot of people ask me, you started off in abstinence-based. Tell me more, Sharita, because what's going on? I think they think I'm just like using cocaine on the side. And I think people have like this fascination with harm reduction, like y'all just out there just getting high all day. And I'm like, no, it's not. It's not that. I'm I made the switch because a lot of people who graduated and completed programs of things that I led were dying. It was really hard to understand, and I grappled with it because what we believed in our field is that if you terminate treatment early, then the results could be death. But it was very interesting during 2020 and 2021 that I was watching, and I'm getting calls from parents and from the medical examiner from Indiana like, yeah, this person graduated from your program 2 months ago. And I'm like, wait a minute, what? What's happening? It's complex. Substance use disorder develops and grows over time. It's not something that happens just wake up one day, now you're dependent, right? Mental health, a lot of times, and what we say with substance use is actually, it is the outcome. It's the solution people have found. So it's not the primary. And that's where we failed with the drug war, was like, attack the drug, right? It's bad, like weapon of mass destruction, fentanyl, it's bad. And we're saying, no, it's the person and what they're trying to grapple with inside. There's a lot of things happening to people. I have people that I worked at Kentucky Country Day School youth who are in very privileged households, but they are dealing with some things that are not talked about in their home. So like our community and the Black community, sometimes we don't talk about certain things outside of the house, and the same happens in all communities. We are very connected. So when we're talking about that dual diagnosis, it takes complex and it takes a variety of an array of services, like having peer support and having people who are harm reductionists on the ground, talking to people and getting to know what's really going on inside helps us address the issues. It's why you see people who start a syringe service site coming to see me, and eventually you find out, oh my God, you went into treatment? Oh, wait a minute, now you're abstinence-based? You don't want to do anything. Well, because in the beginning I started meeting other needs. They were asking me about how to get to a job. They were asking me about, and they noticed that I didn't stop them and say, wait a minute, I see track marks on your arms. They noticed I didn't talk down to them, and they're like, so you're not going to tell me to stop? No, I'm going to say this is a safer route. And now they're leaning in more and telling me what's really going on. Well, you know, I hear voices sometimes, and actually I like to use this one drug because it calms it down. Okay, have you ever talked to another doctor? I have one that comes to my site on this day. If you want to come and talk to him, have at it. If not, it's okay too. And then they're like, wait a minute, are you sure? And they show up sometimes just to see if I'm telling the truth. And then they start walking through the program, and they trust, and they go to these treatment programs, and they'll disappear on us. And 3 months, I just had someone do that. 3 months later, they're like, I just wanted to tell you, I went off to this treatment program, and now I'm about to go into outpatient. Thank you so much. And these are people who people just discredit and discounted and said they're not going to make it. It's amazing. And I have people working on my team like that have gone through these programs.
I would add quickly that we see it, and in the Black and people of color communities, we're not able to always put our mental health first. Mm-hmm. So we function, we have substances that we use to cope. And that is a common thing that happens. And so when that happens, that's why you need low barrier options, because in those low barrier options, as she just describes, I can choose to say, okay, right now I need to focus on my housing first, and then I'll go to therapy. Or right now I need to do, so finding a menu of services that meets each person. So we both and can be true. And it's hard when you have a loved one. I have loved ones who have, one, succumbed to overdoses, and two, who have mental health crisis. And I have some who are still stuck in mental health crisis and are not using substances, but sometimes are suicidal and manic and depressive. And so it just takes the opportunity to connect to what they need at that moment. I think that I hate that happened to your niece. I hate that it happened to DeMontez Campbell, who came here with me as one of my Bail Project clients and succumbed to an overdose, and the person he was getting high with didn't. And so those people live with guilt, which leads to a lot of other mental health issues. And sometimes they end up dead later because they die with that guilt. So that's why the legislation around the murder, death bills, and all of these, it doesn't really connect to the core issues of the mental health, the dual diagnosis. You're attacking one symptom, one outcome of what someone decided to do to get by. But we all are getting by. and we all have different choices to make. So my heart goes out to you, but we do think even that what happened to your niece was preventable, even if you didn't have the answer. If we had more options that people felt comfortable to navigate, we can get help to people sooner.
Follow up, sir.
Very, very briefly.
He's gonna kick us out.
Please.
Okay. Portland now offers free mental health care for everybody 18 and under. They can just make a phone call. They can get in person or over the phone in English or in Spanish. And I really wish as a state we would start using some of this opioid abatement money on preventative care, on actually treating people's mental health and issues before they go to substance abuse to try to treat it on their own. So thank you.
We agree, and we see, and our jails are not meant to be those treatment centers. So if we had more options like that, people can get better sooner.
Absolutely.
Thank you.
Thank you. Thank you both.
Appreciate you all.
Members, before we conclude, I remind you our next meeting and final meeting of the interim will be November the 6th at 1 p.m. We will be hearing a discussion on amending Section 25 of the Kentucky Constitution as it relates to slavery and involuntary servitude. So mark your calendars, November 6th, 1 o'clock. Chair will entertain a motion to adjourn. So moved. And second, we are adjourned.